Now moving on to the perioperative space in general, I know we have Kala from Canada and we are from the US. So Kala, in your practice, how do you incorporate multidisciplinary care for a patient with MIBC and discuss about bladder preservation and other options also?
Yeah, I mean, I think this is the future of bladder treatments and managing urothelial cancer. So we're very fortunate. We have a highly collaborative group. We have a multidisciplinary clinic where we have both the radiation oncologist and the urologist working together and seeing patients together. So usually the flow of patients is they see the multidisciplinary clinic, they may get a cystoscopy, they may get a repeat TURBT if need be, and then pretty much anybody with muscle invasive disease is sent to me for neoadjuvant chemotherapy. I'm a GemCis person, so that's what I tend to do. I do use split dose as well sometimes. To your point, I think it's very well tolerated. We've actually published some work looking at GemCis compared to standard GemCis and even GemCarbo. So it looks like a reasonable regimen. So after they receive their GemCis, they get 4 cycles. After 2 cycles, I scan them just to make sure they're not having any disease progression. Then they get sent back to the multidisciplinary clinic, where again assessed by the urologist and radiation oncologist. And at that point, the decision is made as to whether or not they're going to have local therapy with a cystectomy or potentially be considered for bladder sparing. And at our institution, the bladder sparing component consists of a maximal TURBT, followed by concurrent chemoradiation. It's given over a period of 4 weeks, daily radiation, with once per week platinum-based chemotherapy. And then after that, we follow them fairly regularly, every 4 months with scans and every 3 months with cystoscopy. So this is how all of our patients are managed. Our rates of neoadjuvant chemotherapy use are very high as a result.
Yeah. And what about your practice here?
Of course, it's different, right? So I'll speak to my practice, but community practice in general, this is the gold standard. This is what we all want to achieve to, but the practical realities of community oncology and community urology don't allow for that to happen everywhere, right? So at large community-based centers, you can have these multi-D conferences. Multi-D clinics are hard to set up because of the financial implications across practices. They've been discussed and are out there in a few places, but they're hard to do. But you can do these multi-D conferences, and ultimately, the way patients flow in community oncology is through urology, right? They're getting diagnosed by a community urologist and then getting referred to a community medical oncologist if that urologist feels like they're fit for neoadjuvant therapy. So how to bring in trimodal therapy really involves engaging our urology colleagues to think about it. And those who are out there versed in the data, they're doing this. And we've done, in our practice, trimodal therapy for a few patients this past year because we are seeing the benefits of that and they're doing well. I do think, though, it is a big lift to get this done and spread to the 80% of patients in America that are treated not at academic centers. It's going to take more data. It's going to take really robust, large data sets proving that it is a valid strategy. It's not a non-toxic strategy. And we also have to decide how we're going to give it because everyone's doing it differently. Some community clinics are giving neoadjuvant chemotherapy followed by chemoradiation, right? And other groups are jumping right into chemoradiation after maximal TURBT. We don't know which way to do it, right? So I think we're going to rely on you guys to help us figure that out because those are the types of trials that we can help participate in community oncology, but are also going to be way harder to do because of the practical situations of 1572s and different practices. Now, some groups do have urology and med-onc in the same. Those would be easier to do that kind of work.
Yeah, even in academic settings, I think our rates of bladder preservation are very low, unlike in Canada and I don't know what.
Yeah, having done part of my training in Canada, I think they're definitely the gold standard of really offering both patients equally to patients. I don't think we're at that level, you know, in what I've seen in my experience in the US. But I think, you know, hearing bladder cancer advocacy groups, bladder preservation is such an important factor for quality of life for patients. And hopefully, you know, in a decade or so, we'll be talking about even more, you know, bladder preservation options that maybe don't even involve radiation, where we're just systemic therapy based alone. But I certainly, because a lot of elderly patients, you know, often are the ones that are diagnosed with bladder cancer and the surgery is very involved, I try to offer bladder preservation options. And beyond just IV treatments, there's some data for even oral capecitabine for patients to just get it Monday through Friday along with their radiation as an option to even avoid infusion visits and things like that. So I think it's nice that we're moving to more options for patients, and hopefully it will continue to be the case specifically for patients that want to preserve their bladders.
Yeah, especially with, if drugs like ADC and immunotherapy combinations like EV-Pembro move early on and patients have complete clinical responses, then there'll be a big question of, do we really need to do anything?